This meeting is being recorded.
Okay, will I start? Do you think everybody?
Yeah, hold on for a second, Elaine. We'll just let people trickle in for the moment. So give people a minute to come in, and I've seen lots of you coming in as we open up for this evening's webinar. You're all very welcome. My name is Elaine Donnelly. I'm one of the social workers here in St. Patrick's Mental Health Services, and tonight I'm really delighted to be joined by my colleagues Elaine Murphy and Laura Pearson to talk about young adults in recovery. So for some of you, you may have already joined our webinar series. You can find the full recordings on the St. Patrick's Mental Health Services website. Please do whatever you need to do within the next 40 minutes or so to take care of yourself, and safe in the knowledge that you can always take a break if you need to and come back to the recording at another stage. We will have short time for Q&A at the end, so please feel free to put any questions into the Q&A box, and we'll get to them if we have time, and hopefully we will. So without further ado, I'll hand over to Elaine and Laura to get kick-started for tonight's presentation.
Hi everybody, thanks for joining us tonight. We have just going to put up a PowerPoint there to start with, so just bear with me. My technical skills aren't fantastic. Okay, so yeah, as we said, thanks a million for joining us this evening. We are going to focus, I suppose, specifically on young adults' mental health, and supporting family members to support their young adults as well. So as Elaine said, I'm a social worker working in St. Patrick's Mental Health Services, and I currently work with adolescents from 12 to 18 and on the young adult team as well, so 18 to 25 and a little bit over as well. And I'm joined here today by my colleague Laura, who is a family therapist also on the young adult team. So our title for tonight is Supporting You to Support Them. So navigating your young person's admission and recovery, a family perspective. But I would like to also welcome any young adults that are joining as well for more information and advice. And as Elaine said, we will have an opportunity for questions at the end if we have a bit of time. So I'll just, I suppose, move on to our first slide there. And I think the one thing that we want to do is acknowledge family stress or distress when when a family member is struggling with mental health. It can be a very scary time, especially when it could be first time accessing mental health support or trying to navigate, I suppose, that system as well. There can be a lot of stigma associated with inpatient admissions. And there can be a lot of unanswered questions and unknowns, which can drive up fear and worry for anybody. So we just wanted to take a minute as parents and young people to recognize that there may be high levels of stress and worrying in the family at the moment, and how important it is to acknowledge this among families and with young people as well. So I suppose that the one thing to make clear today is that we are not on our own. St. Patrick's Mental Health Services are here to support the young person and family members as well through a range of different supports that are available as inpatient and outpatient. So today we hope to ease some of these worries and fears and provide detailed information on what an admission, either a physical admission to the hospital or a home care package might look like, and then what additional services are available to family members and the young person, and obviously after discharge and aftercare plans. So today, this is what we aim to cover. Hopefully we'll get through it all. So I will talk for the first half, and then Laura will, I suppose, provide a better insight into sort of the family dynamic piece and the difficulties that arise for family members and improving relationships as well. So the first half I will cover. So what does an admission look like? The hospital setting, the ward setting, and a home care package as well, what that might look like. We'll discuss the multidisciplinary team, the referral process for individual disciplines within the multidisciplinary team, what a psychology formulation assessment might look like, the role of a key worker, sharing of information, discharge planning, our young adult program specifically, what social work and the family therapy department can offer. And then Laura will continue with building and maintaining family relationships. And then at the very end, we have a list of community and sort of national supports as well, where you may be able to gain extra information. Okay, so what does an admission look like? And an admission to inpatient care is sort of recognised as a crisis intervention. So what I mean by that is typically mental health treatments are offered to people living, in their own homes in the community. But if things become more difficult and mental health distress increases, an admission to an inpatient facility like St. Patrick's Mental Health Services might be considered beneficial. So an admission for anybody, young person or older adults, is tailored to each individual needs to ensure, it's tailored to everybody's individual needs, but most admissions will take a similar sort of process or will follow a similar path. And the service user will have weekly meetings with the consultant to assess their mental health needs and their progress. And that also helps build a good rapport with the team and gives the team an insight into how best to meet the specific mental health needs of that person. Also supports an opportunity to build a care plan. So at the start of the admission, the service user will be assigned a key worker to support them accessing and sharing information, advocacy and sort of general support. And the key worker is the main point of contact for the family. So I think we come across, yeah.
Is there a screen sharing set up there just for the slides?
Oh, is it not coming across?
No.
Okay, sorry, I was going on there. Okay, I'll try that again. Apologies about that.
No worries. Yeah, thanks, Elaine. Yeah.
Sorry, is that coming up now?
Yeah, perfect. You can see it now.
Oh, we can see it now. Okay, sorry, it come up on my screen. Yeah. So apologies for that. You missed some of my wonderful PowerPoint slide skills there. But we'll continue on. So yeah, so just getting back to the role of the key worker, I suppose, is very important in regards to keeping sort of communication lines open between the hospital, service user, and the families as well. So I think especially during COVID times, family members felt a little bit out of the loop. So having somebody that you know their name, that you can contact to ask any questions you may have or to gain more information on your young person's admission can be really vital. So that's a fantastic service. I suppose that can help as well for the young person in regards to accessing additional information through that's available through the hospital. And also the key worker is the main point of contact, I suppose, with the service user and the team in regards to advocating their needs or tailoring their care plan a little bit better. So each person receives an individual care plan, which outlines the treatments that the team have identified as being, most important and beneficial in supporting recovery in mental health. And discharge planning is also initiated within the first week of admission as well. So this discharge planning is started that early because it's recognized that a lot of the hard work begins after discharge, and it's important to make sure that all the right supports are in place, and it gives the team time around planning, and it gives the service user a good understanding of what additional supports they'll receive after discharge. So service users may be referred to inpatient programs. which will support skill building and resilience. And some of these might be the anxiety program, bipolar program, or the young adult program as well. So the decision around referring a young person to these programs is, made through the initial assessment, which takes place in the first week or two. And that allows us to identify specific needs and helps us, I suppose, to direct people in the best way possible. So a psychology assessment might be recommended as well to support formulation, to support the team to understand, I suppose, what what the young person has been struggling with around their mental health and any specific needs that need to be addressed. So the psychology assessment piece is done over a couple of weeks, over a couple of weeks, and the psychologist will meet with your young person one-on-one, and we go into that a little bit more further into this PowerPoint as well. So there's also a great access to complementary therapies as well, such as art therapy, pottery, music therapy, mindfulness programs, and other general activities such as yoga, Zumba, and recreational activities. And these are really important as well. It's important to get the right balance for a young person in regards to looking after their mental health. As we know, self-care is really important. So we strive, I suppose, to encourage young people to engage in alternative recreational activities and to also engage in other supports like art therapy and pottery, as it allows them to create, I suppose, a more creative side, as well as exploring their mental health and building their resilience. Sorry, just move on to the next page there. So the hospital setting itself, so St. Patrick's Mental Health Services has two sites. We have one just up from Houston Station, and also one called St. Edmundsbury, located out in Lucan. So St. Patrick's Mental Health Services at Houston Station has 9 specific wards, and in St. Edmundsbury we have 40, I think it's around 49 single rooms, which at the moment that facility is currently being used as a COVID-19 isolation ward for anybody that's presenting with the virus. So as well, in the hospital setting, we have a range of facilities, including a gym, craft rooms, group rooms, a library, a full list there on your screen. We also have, a hairdresser, outdoor garden space, pitch and putt, cafe and shop, and lots of areas, I suppose, to meet and spend time with families. We also have a year-long event calendar to celebrate seasonal occasions, World Mental Health Day, Founders Day, and as well as other, day-to-day activities. And I think one of the high points for a lot of service users is that we have a couple of ponies that come in to visit once a week, which is a great occasion. So the ward setting as well, each ward has a similar layout. There is, I suppose, it does have, most wards do have a similar layout, but some wards are specialised in meeting specific needs of the service user. It could be a female only ward. We have a older adult ward. And then, the likes of Temple ward, which supports people with additional dependencies, and then we also have a separate ward for people that struggle with disordered eating as well, and that's specifically to meet the people's needs, as they may not be as easily met on a general ward. So the ward itself, there's shared bay areas, private rooms, clinical rooms, meeting rooms, group rooms. I suppose that there's lots of different facilities. So initially, when your young person comes in for a physical admission, they may have to spend some time in a bay area for assessment purposes and risk assessment, and to ensure, that they're feeling safe and settled in themselves before being offered a single room. And a single room is typically offered, in regards to sort of meeting the needs of the young person as well. If somebody feels that they need to be closer to the nursing bay, they may spend more time in the bay areas. So young people will be orientated to the ward with a chance to ask questions and, understand the environment itself, how to access different supports, introduced to different staff as well. It's a very welcoming setting. There's nursing staff available 24 hours a day. There's lots of different activities that happen on the ward as well, day to day, to help people sort of familiarize themselves with the environment and get settled and feel a little bit more comfortable. So peer support in the ward setting can be very beneficial for service users as well. There can be a lot of nerves and worries coming into a new environment, but maybe getting to know a few other service users can, I suppose, help reduce those fears and worries and support, finding out more information and understanding, I suppose, how the system works. So we also have 2 other wards, one which cater for people that need extra supports in regards to minding themselves and minding their mental health, with additional observation and I suppose more specialised attention depending on their needs. So that we just covered the inpatient setting. So we also offer a home care package as well to young adults, depending again on their own unique needs. But the home care package is offered out to those who would prefer accessing care at home, and it supports a service user to access, I suppose, the full range of MDT disciplines that could be available if they were a physical inpatient as well. So typically a home care package would sort of involve 2 support calls a day from nursing staff, 24-hour support available if needed, weekly online meetings with the consultant, and then, depending if referrals are made to the rest of the multidisciplinary team, like psychology, CBT, social work, they'd also, those sessions will also take part online. As we said, full access to the multidisciplinary team, and also access to group programs, all facilitated online. So what does the multidisciplinary team look like? So there is a range of different disciplines that work together as a team to meet the needs of the service users. So we have a description there just on the PowerPoint. So the multidisciplinary team is a group of healthcare professionals who are members of different disciplines, each providing specific needs to the patient or the service users. We prefer to use that term. So the team may look a little bit different depending on maybe the speciality of the team or the group that they're catering for. But typically the MDT would have 4 to 5 different disciplines available, and the psychiatrist is the clinical lead. They may also have a team liaison nurse who works closely with the psychiatrist and the service users and family members as well. We have a full nursing team, psychologists, CBT therapists, so that's cognitive behavioural therapist, social work, occupational therapist, pharmacist, family therapist, additional healthcare staff, addiction counsellors where needed, art therapists, and a range of other disciplines, depending, I suppose, on the specific needs of each service user. Okay, we've gone back. Sorry. Okay, so typically, when a young person comes in for the first week or 2, they undergo assessments, with the psychiatrist, the consultant, the lead consultant. The nursing teams will make observations, and the multidisciplinary team meet each week to review each patient and to identify, what services can be offered and what approaches can be offered to support mental health recovery. So typically a referral will be made by the psychiatrist to the other disciplines on the team. depending on the needs. So the specific disciplines such as psychology or occupational therapy will review a referral made by the psychiatrist and then make direct contact with the service user themselves to arrange an appointment for assessment. The service user can then decide if they want to engage or if they don't want to engage with that service, but we would promote, I suppose, as much engagement as possible. Then the service users refer to the specific group programs, maybe through psychology or CBT, and then also referrals to the MDT can have waiting times as well, which we're quite aware of, but we try to ensure that those waiting times are kept as short as possible. But the specific disciplines will make, as I said, make direct contact with each service user, complete a short assessment, and then I suppose start doing some psychoeducation and therapeutic work with the young person. Okay, so I suppose specifically for young adults in St. Patrick's mental health services, we have a young adult program that's available to all young adults 18 to 25. So I suppose the aim of this program was to increase sort of self-esteem, facilitate recovery, and learn about sort of managing mental health difficulties and promoting mental health wellness. It also encourages sort of structure and routine for young people when they are in the hospital setting as well, because it can be difficult, I suppose, to maintain that, which we recognise as something that's really important in supporting mental health recovery. So the programme, as I said, is available to 18 to 25-year-olds. It's designed to provide young people access to peer support, information, skill building, education, and mental health wellness. And it's delivered through group sessions, leisure activities, peer support sessions. And it just helps, I suppose, the service user build a rapport with the different members of the multidisciplinary team and other service users that are accessing supports. So at the moment, due to COVID restrictions, we are running that online. Feedback we've received has been quite well, has been quite good in regards to the young people, I suppose, being able to meet other service users and get to build, I suppose, their own knowledge on supporting their recovery. So when I identified earlier on that psychology is one of the disciplines available through the MDT, a lot of young people, I suppose, that access St. Patrick's mental health services have an idea that they may be able to have, access psychology sessions initially or straight away. But one of the things that we wanted to inform everybody today was that psychology in St. Patrick's University is mainly focused on the assessment and formulation piece. And it encourages, it helps young people understand, I suppose, the challenges that they've been facing, over the past, either short-term past or long-term past. It helps answer questions in regards to, those challenges they've been facing. It might help them identify areas that they can build on to reach a stage of recovery as well. So if a psychology assessment is deemed suitable, the service user will be supplied with questionnaires and specific measures that identify areas which may be causing mental health distress. The psychologist will then meet with the service user to review the outcome of these questionnaires. They'll also build a rapport and spend some time exploring psychological challenges that people have been facing. So the formulation piece, after 2 to 4 psychology sessions, the psychologist will present, I suppose, a formulation to the service user to help them understand those challenges that they've been facing. And the psychologist will also sort of discuss the outcomes with the rest of the MDT so that we can best, I suppose, put a support plan in place to try and support the service user to build resilience, coping mechanisms, and to direct them to a specific psychological interventions to support their recovery. So by doing that, the psychologist will make those recommendations either for group programs within St. Patrick's University Hospital, or maybe one-to-one therapists as well in the community, depending on the unique needs of the service user. Okay, so we're just going back to the role of the key worker that I mentioned earlier on as well. So the key worker can be a really important person to utilize, whether you're a family member or you're somebody actually accessing the supports within our service. So a key worker, as I said, is assigned to each service user within the first week of their admission. They're the direct link between the team and the service user and the family. They provide information and guidance on how to access inpatient resources, provide support to understand the care plan that's in place, go through the full care plan in lots of detail, give plenty of time for the young person to ask questions, and also the family members. And then they're also, I suppose, the main advocate for each person within the multidisciplinary team. They ensure the care plan is being followed and being updated, so that it reflects, I suppose, a very sort of present moment in regards to the treatment plan. And then the key worker also offers support to service users around discharge planning, which is also really, really important. So, and then the final role of the key worker then is to provide a direct link between the family and the MDT, answer any questions the family may have, and support the family to access further information, rather through community services. We have an information service available in the hospital as well. And I suppose if there's any really very specific questions that need to be answered, they can also support that as well. And again, with discharge planning. So I think something that we recognize in regards to supporting family members around accessing information about the young person's admission, the family can have challenges in regards to that. So as somebody turns 18, they have a right to control what information is shared with their family members, and they need to provide consent to the team for us to be able to share that information. So if consent is not provided to share information, this can be very challenging for families when they're very worried and they're fearful, of not being able to gain, that information that they might need to support their young person during their admission and when they come home. And it can be extremely frustrating. That's something we recognize. So information sharing is key to supporting families to building their own skills, but we can also recognize that if there's any difficulties within the family or their loved one decides to decline to provide consent, that this can be, very upsetting process. We try our best to, in this case where if there isn't consent provided, we try our best, I suppose, to provide some general psychoeducation to family members in regards to how they may support their young person after admission. We also help on supporting communication skills, between family members where needed to try and build family relationships and I suppose improve outcomes in general. So as well, I suppose we have recognized a need, for families to have this information, because I suppose the hospital setting itself and the MDT are only involved with young people for a short period of time. We recognise that the family are key in regards to supporting recovery over a longer period of time. So family meetings are on offer when the young person consents to them, and that gives families a chance to meet with the consultant and other disciplines within the MDT to ask questions and to gain better, a greater insight into the future care needs of their young person and the recovery process as well. So discharge planning, as I said earlier on, is something that's really important. It started within the first week of the admission. It's something the team work on throughout the assessment process and the treatment process. Family meeting is offered, as I said, closer to the end of, closer to discharge to discuss, you know, the difficulties that have been identified, sort of final diagnosis, and the follow-up care, which is really, really important. So a clear plan is offered to each service user in regards to the follow-up and the recommendations that will be made. And upon discharge, a review meeting will be set up with one of the nurses through the Dean Clinic within 30 days, just to, you know, assess how the young person has got on since their admission. Have they been able to, I suppose, follow their aftercare plan, you know, and just to check in general in regards to how they've been maintaining the recovery process. A discharge summary is also sent out to the GP as well, and to any other services that may be involved, maybe a community psychologist, community mental health team, not anybody else that will need to have that information, so that we can give a good understanding of the work that the young person got, you know, did on their improving their mental health while they were accessing inpatient stay. And prescription for medication is also sent out to the service users' nominated pharmacy in the community as well, upon discharge, so that they can access medication if medication is deemed needed at that time. Okay, so follow-up care options as well. I know I'm running over. Sorry, Laura, I know you're dying to get in there. I won't take too much of your time. So the follow-up care options in regards to accessing further mental health support after admission can be, one option can be through our Dean Clinic, which is our outpatient service. The Dean Clinic is a part-time service with access to consultant, nursing staff, occupational therapist, social work for crisis intervention, psychology for group assessment, CBT therapist, and depending, I suppose, on the team as well, a family therapist might be available. When a service user does access outpatient supports with the Dean Clinic, they can also access group programs depending on their own unique and individual needs. And then another option for follow-up care is the community mental health team, which is offered through the HSE, a public service. But depending on the needs of the individual service user and their wishes, I suppose a referral can be made to the community mental health team. So they also have an MDT approach, but I suppose each individual catchment area could be very different depending on what resources are available. They also offer crisis intervention, and they can also offer family supports and group programs. And then I suppose the third option then would be a referral back to the GP. So if a service user has made a good recovery and is feeling more stable in their mental health journey, a referral to the GP for ongoing monitoring support can be recommended. And I suppose one thing to recognise that GPs have a wealth of information on extra support services that are available in the community for individuals and their families. So I suppose just getting back to the role of the social work department, the social work and the family therapy department. So mental health social workers support individuals, the families and communities as they seek to overcome challenges. The social worker on the MDT can provide direct support to the service user and the family to help, I suppose, with a wide range of difficulties, such as family relationship dynamics, accessing information, support, advocacy, and psychoeducation. We recognise that communication within families can be strained at times of crisis, and we can offer supports or a supportive space to explore this and to, I suppose, build communication skills to strengthen and improve family relationships. So the social work department also offer information and support, which we recognise as key to recovery. We have a wealth of knowledge and experience of working with, with young people with across the board, I suppose, from young adolescents right into older adults as well, and family members. We offer a range of group supports through Family Connections, which is one particular group we run to support family members of loved ones who have been given a diagnosis of borderline personality disorder or emotionally unstable personality disorder. We also do Parent and Skills program, which is offered through our adolescent service. We facilitate or co-facilitate with other disciplines on other programs such as the Pillar to Wellness, Eating Disorder Groups, Access to Recovery, RAP, and the Bipolar, and many more. I'm probably missing out a few. If you need to access any more information on the family services and group services that are available, please don't hesitate maybe to ask at the end of this, and we'll be able to direct you. So social work also play a very vital role in safeguarding children and vulnerable adults within the hospital setting as well, and we take that very seriously. And then our family therapists offer sort of therapeutic assessments with sort of in regards to the family dynamics and the context, and an opportunity to have new conversations and provide, I suppose, direct input with families, and also can make recommendations for follow-up in regards to community family therapy services and maybe outpatient through the team clinic as well. So that's all I am sharing today. And if you guys have any questions today, please don't hesitate just to wait until the end of the PowerPoint to ask them, and hopefully we'll be able to answer. So thank you very much for your time. And I would like to pass you on to my colleague, Laura. So I'll just stop sharing there, Laura, if you want to do yours.
Yeah. Elaine. I know from meeting families that just getting their heads around the structure of the hospital can be really difficult. So actually all of that information, I think, gives a really good insight into all the workings, in particular of the young adult team, which I know can be totally confusing sometimes to families and young adults. So I'm just going to share my screen here. Bear with me to make sure this actually works. 2 seconds now. Share screen. Here's my PowerPoint. Share. Now, try and maximize this. And play from current slide. That looks good, does it? Great. Okay. So yeah, I suppose this is part 2 of myself and Elaine's kind of lecture this evening. I'm trying to support families really to support their young adults, and really I'm going to focus kind of in more depth on family relationships. So I am the family therapist on Dr. Power's team, and I suppose in terms of what I can offer, as Elaine kind of started the conversation there, in terms of family therapy, is really trying to assess the family context first of all. So gathering, I suppose, a huge amount of information from the young person, and then trying to make a little bit of a plan in terms of who they want to invite into the sessions, you know, whether that be extended family members, whether that means parents or siblings, or sometimes young people actually might choose to just do some individual work with me. So they might like to just step back and kind of gain a little bit of perspective on what's happening in their family. So I suppose that the family therapy intervention can be very flexible. And I suppose at the end of the intervention, I always like to ask families whether, you know, they would like a recommendation for follow-up in the community, or they feel like actually the conversations that they've had while their young person has been in hospital kind of feel like enough for now. And I suppose really one of my main jobs on the young adults team is really to help families have the opportunity to talk about things that maybe they haven't talked about yet. So they know maybe at the back of their minds that it's something they kind of need to get to at some point. Maybe the crisis in terms of their young person coming into the hospital has pushed those conversations to the fore in a way that maybe they didn't expect. And I suppose I'm always really conscious that there could be siblings at home, there could be grannies living at home, or other family members who, you know, I suppose maybe need that gap almost to be bridged between what's going on for their loved one in hospital, trying to understand that. And I suppose I would see my role as trying to help those pieces come together as well. I suppose I always remind families that when they come to me, family therapy is really just one piece of the MDT puzzle. So you know, often parents don't necessarily obviously get to meet the psychologist or the occupational therapist, or CBT therapist on the team. So I suppose it might feel like the family dynamics are really being focused on when they meet me, but actually it's a small part of a large piece that's going on. In terms of, I suppose, all the work that's going on behind the scenes that their young person is doing as well. So I suppose today I really want to kind of hone in on that idea that lots of families kind of come into me and they ask, or maybe they won't ask it out loud, but there's certainly a feeling in the room of kind of, are we the only family that this happens to, or are we the only family where this issue has come up? Because there can be such a feeling of isolation, I suppose, when a crisis has happened. I suppose there can be maybe secrets around the young person's mental health, or maybe they're not ready yet to share certain elements of their mental health with their friends or extended family members. So I would hope that maybe if there's family members in this lecture today, that you might leave at the end, I suppose, knowing that there's lots of common themes that go on, I suppose, in families where there is mental health difficulties that are essentially quite normal. In a sense. So there's three themes that I'll kind of go through now, and maybe just give a little bit of an opportunity for I suppose whoever has joined us today to kind of just reflect on a little bit, and maybe think of something new, or maybe not. So I suppose the biggest theme in terms of the young adults that I work with when they come into the room is this idea of them being launched into adulthood by their parents, you know, kind of like a rocket ship, that sometimes has really stalled, and actually, in a sense, mental health difficulties, I suppose, throughout young people when they're in their 20s, there's this strange contradiction happening where maybe they should be leaving the family home, or they should be going to college, and there's maybe all these norms they feel like they're not meeting. Whereas actually they just want to, maybe they want more comfort from their parents, they want to be at home more, they want to be feeling nice and safe, and I think parents that I meet sometimes are totally confused, because they're thinking, okay, well, on one hand I know that I need to foster their independence, and I have expectations for them in terms of being a young adult who maybe should get a job or things like that, and then on the other hand their young person is saying, you know, I really don't feel up to it today, you know, I really need to be looked after, mind me a little bit more. So I suppose I acknowledge for parents in particular, it's a balancing act, and you're probably walking a tightrope most days in terms of knowing what the right thing to do is. And there's also that idea in terms of, I wrote the family life cycle theory here, but sometimes when I meet young adults, their parents are maybe coming to retirement age. I'm kind of talking in really general terms now, but they might have, I suppose, their own hopes and wishes and plans. They might want to travel, or they might want to have projects together to do. And actually, the young person's mental health is kind of pulling them back into more of a caring role where maybe they had never expected to be, and they had never expected to maybe be at this point, in terms of refocusing a lot more care on their young person than before, possibly. And I suppose I just wrote down the end there, I suppose there is cultural aspects to talking about this idea of launching people into adulthood. Obviously at the moment, I suppose there is a housing crisis, so, you know, things like housing where we would have expected our young people to leave home possibly, it is obviously being impacted. So I suppose it's just about acknowledging that as well. So another, I suppose, huge part of my job is about identifying family patterns of communication. And I suppose that sometimes well, actually all of the time, not sometimes, families come into the room and they, of course, they just want to get it out and they want to share everything. Sometimes that means having a big argument. That's fine with me. We can do that. Or sometimes that means going really slowly and taking lots of time to feel safe enough to talk about kind of risky things. And I suppose as the family therapist, I'm always really interested in maybe the patterns that happen underneath all of this talking and content. And generally speaking, I suppose when I work with families, we try to map out, okay, so maybe you get into an argument with your young person, maybe you've offered advice, maybe they push back a little bit, maybe they go to their room, they retreat even more. As a parent, you might be feeling a little bit bruised, a little bit like, okay, I offered some help, they don't want it, what do I do next? Maybe I'll pull back a little bit more. And before you know it, I suppose there's maybe lots of distance between you and your young person. So I suppose all types of patterns play out with families. And I suppose I'm really keen on reminding families that, it's not really about, I suppose, blaming one person in the family. It's more about there being all these different layers, and all these different kind of pings, and I can almost see it in my head of kind of these lines, like a big ball of wool actually, that are going on. And our job, I suppose, in the family therapy room is to pick these little bits apart and understand the pattern. And once we know, I suppose, the pattern that keeps playing out in a family, we can begin to interrupt it. And I think that's where parents maybe have probably not really understood what I was talking about up to that point. And then they go, oh, okay, so we can make a choice maybe to relate to our young person in a different way. And the same with the young person, I will always put the responsibility on them as well and say, okay, well, you can make a choice to communicate with your parents in another way. So I suppose that usually takes a good few sessions, and can be quite complicated work. I think families will probably agree with me too, because we're all used to, I suppose, relating in a certain way to our families, and sometimes, that has been ingrained for years and years and years, and it's very difficult to do something new. So my third theme here, it's kind of a little bit wordy, so it's called intergenerational family scripts. And really what that mouthful means, I suppose, is that when, for example, I'm in the room with young people and their parents, I often get invited into, I suppose, meeting people who maybe have passed on, are from maybe the generation in terms of grandparents, or maybe close family friends and things like that. And often these are very influential figures maybe on parents that I meet in the room. And I suppose maybe family therapy, there's a little bit of an expectation that I suppose I do get to know those people. Because that gives me important information about family stories, maybe about how patterns of relating have been passed down. And I suppose one thing that I often talk to parents about is maybe what they experienced growing up. And I suppose one thing's for sure, they never thought that maybe their young person would be in St. Pat's. And right now, I suppose, while we have the opportunity, we might stop and pause and say, okay, I suppose, were there things that you wanted to do as a parent? Were there things you didn't want to do as a parent? And I suppose more often than not, of course, parents say to me, gosh, no, we're 20 years down the line, or 25 years down the line, we haven't had a chance to kind of stop and pause. So really it's an opportunity to kind of reflect on maybe where you got your parenting style from. Often parents might say, oh, there's something my mum did and I absolutely don't want to do it the way she did. Or it might be the opposite, and it might be, yes, there's something, really comforting that my mum did growing up, and I want to pass that on to my children. So again, it's about really sorting through those kind of nitty-gritty ideas. And I suppose, again, I'm always really interested in the idea of comfort. So how did parents get comfort from their parents, and how did they pass it on? Because I suppose it can give me lots of information into how families relate. Yeah, let me just move on to that part. Yeah. So I suppose I wanted to finish on the idea hope. We probably could have started on it as well, Elaine. But I just want to acknowledge, I suppose, that often, you know, when I meet families and carers, or whoever is important to the young person in the room, they are trying so hard to hold out hope for this young person. Because ultimately, I suppose the young person that I meet has often lost all hope. And I suppose that is a really incredibly difficult job for carers, because I suppose everything in the kitchen sink has been thrown at you up to then. And I suppose I would like carers to know, probably at the end of this lecture as well, that I suppose all of the MDT that Elaine talked about, that is also our job too. It's about holding hope for the young person, even if that's a tiny little chink of light. I suppose it's really important that we do that as a team. If you feel like, okay, actually, you know, right now it's too difficult to see that. And I think things like guilt and shock for carers often get in the way of seeing that hope. So I think a huge theme that I see is parents who say, how did we not know about this sooner? I suppose they're looking back and thinking, gosh, was there things we could have done? You know, we actually had absolutely no idea. And actually, lots of parents are still coming to terms with that while their young person is in hospital. And I think even thinking about care plans and discharge plans and things like that almost feels a bit fast, because as parents you might still be catching up with the fact that your young person is in such pain and distress. And I suppose what I would say to that is that often young people say to me, do you know what, I really, you know, I find it really difficult when my parents do offer me advice, and parents are saying, well, you know, I want them to go for a walk, and maybe the walk will help their mental health on that day, and they'll feel a bit fresher, and it might start the day off right. And actually lots of young people say, do you know what, I just need a listening ear. I just need my parent or carer or whoever's at home just to be present. So I would hope that might take a little bit of pressure off parents maybe who are listening this evening. Absolutely, you do not have to come up with the solutions there and then. I suppose you don't have to come up with the care plan and things like that. It's really about just parental presence. So being there, giving your young person invitations to maybe have a chat, and they might say no that day, and then they might come back in 5 days later. So I suppose I wrote there quite casually, but it's about just showing up consistently. And I suppose that can be really difficult when things like guilt and shock and pain and upset are also going on for you as carers. Yeah, so this kind of ends with a bang in terms of community support services. Really conscious that carers are doing really difficult jobs and are often jaded actually by the time their young person comes in to see us. So I suppose maybe there's one service I really want to point out in terms of individual psychotherapy for parents, or I suppose, you know, seeing a family therapist as a couple themselves outside of St. Pat's. So I have the IACP there in terms of looking for registered therapists and registered family therapists on the Family Therapy Ireland website, because I think we just can't overstress enough getting the support for yourself and making space for yourself in among, I suppose, all the difficulties that are happening. And just to slow it down a little bit for yourself, because you have to be sustained in some shape or form. There's lots of names there of different places, and I suppose this will be up later, or if anybody wants to take a picture of it now or anything like that, to kind of record and keep it in mind. So yeah, I suppose with that said, I'll stop sharing now, and we're absolutely open to any questions or anything like that.
Thank you both for that really informative presentation. If anybody has any, okay, there's just one question coming in now. If anybody else has any questions, we have a few minutes, so please feel free to pop any questions in the chat. One participant has asked, do we have any help for ethnic minorities, specialists, different languages?
So we do have access to interpreter support. Because we would be quite used to having an interpreter in the room and kind of discussing with families how we might go about that. So I suppose from my perspective, I only speak English, and would call on other supports in terms of the language piece where needed.
But there definitely is, I suppose, psychotherapy associations which would have the capacity for you to be able to filter via language as well, so that you can find a therapist maybe in different languages and with different accessibility maybe requirements.
For individual support, I mean, there's actually a really good new therapy group called Black Therapists Ireland as well. Just in terms of if anybody was looking in that regard, they're a very new group who offer individual psychotherapy as well.
We have another question from our participant, which I think would be quite a common occurrence for you both, and it's something that we see very often. A young person is reluctant to share elements of the care plan and no contact from the team as the young person is over 18. We know this can be a particularly difficult challenge for particularly those who've come from maybe a CAM service where involvement has been of a more moderate intensity, and that really is a sharp drop off when the person turns 18. Have either of you, from your own experience, how to manage that for this parent?
Yeah, absolutely. This is something I suppose we come across regularly enough, and it can be extremely difficult for the family, I suppose, when they're lacking information, lacking insight into specific care needs or what's going on for the young person. The one thing that we encourage is communication as the really key piece here. Checking in with your young person, trying to build that communication, offering your support and guidance. Maybe, as Laura mentioned earlier on, maybe not offering solutions, but more of a listening ear to build that relationship piece, to support or to help your young person understand that you are a part of their support network. And it is important for you to have contact maybe with the team or a greater understanding of the care plan. We do recognize that it's extremely frustrating for parents, and it's frustrating for us as team members as well, because we recognize that the family support piece is key here. And unfortunately, our arms can be tied at times, but we constantly try over and over and over again to encourage the young person to look at it from a different perspective, as as family members are there and available to them 24 hours a day, whereas the team may not be after discharge, and that family can provide a huge amount of daily support, help them even get into appointments, organizing different things if needs be, if that's what they need. So I suppose just keep in mind that from a team's perspective, we are constantly working on that to help the service users themselves understand how important it is to have family involved. And I suppose from the team perspective, we also understand how frustrating it is for family members too. But I think it's just that the communication is definitely key there in helping your young person understand the importance of having family support.
And I think to remember that consent can change, that somebody
can
with refuse consent at the beginning of the admission, depending on maybe how vulnerable they feel. And that can consistently always provide information, that your right to provide information stays the same throughout. And usually best to do that in writing to the treating team, maybe that your loved one is under the care of. There's another question now. I suppose I'm conscious that we're speaking about young adults, so those persons aged 18 to 25, but somebody's looking for typical signs of social anxiety in a 7 to 9-year-old, and whether they come on suddenly or gradually. I think perhaps, unless either of you want to add in anything at this point, it might be helpful to direct participants here who might be looking for information about the adolescent mental health to the adolescent mental health webinar that's on the website, as it might be more applicable to
I think as well, just as a tip offhand, like I'm sure maybe this parent has done this, but checking in with the school teacher, because school teachers really have a really good sense of like what would be the norm for a 7 to 9 year old. You know, they obviously are seeing young kids every single day, and so they would have a really good sense of if something is a little bit different for this child, what they are noticing.
And also, I suppose your family GP is, I suppose, the first port of call as well if you are worried or concerned about your child, your adolescent, your young adult as well, as they have obviously a wealth of experience and also have a wealth of information around additional community supports. And accessing mental health services as well, rather through the community or through St. Patrick's Mental Health Services.
Okay, thank you both. We don't have any more questions for this evening. So we'll finish here for tonight. Thanks to all our participants, and especially thanks to our 2 speakers tonight. Hope everybody has a good evening, and the recording will be available on the website to watch back in the coming days. So take care.
Thank you.